Welcome to today's webinar, where we will be discussing what common and uncommon blood tests reveal about cancer risk. Dr. Nalini Chilkov, the founder of American Institute of Integrative Oncology Research and IntegrativeCancerAnswers.com. We will be hosting a Q&A session at the end of the discussion, so please feel free to drop any questions you might have into the chat box.
Thank you so much. Okay, thank you so much for having me. This is Dr. Nalini Chilkov. I have a lot of slides today. I want to talk about the role of biomarkers in assessing the cancer terrain. And this is really about you as primary care in the trenches, clinicians, understanding how to recognize early signs of cancer in your patients or early signs of recurrence, and how to track them maybe while they're going through treatment so you can support the health side of the equation. So we're going to look at what appears on your lab test that you are looking at anyway, and then how to really use that information. So disclosures, I have an institute, the American Institute of Integrative Oncology Research and Education, through which I teach this Outsmart Cancer system, which you'll get a taste of today. And I also have a free website for patients and families whose lives have been touched by cancer, Integrative Cancer Answers. And there's a lot of free information there for patients and families. So this is what we're going to talk about today. We're going to look at some prognostic and predictive biomarkers that reflect the cancer terrain or the tumor microenvironment, which is the signaling environment, the biosystem in which cancer has been permitted to arise and proliferate. And so we'll look at these biomarkers, and you'll get a sense of how to assess that in your patient. And I wrote an article called What Common Blood Tests Reveal About Cancer Risk. And so there's a link for this. This is a gift for you, and it will give you, some extra notes and details and a little bit of a cheat sheet for yourself. And then for those of you who are interested in my professional online training, it's all self-paced and it's online. And plus there's the option to have live mentoring from me on a monthly basis on a live call. If you get interested in that, offering everyone who comes through Emerson and Wellevate a 10% discount, and you use this code Emerson10. So you can always come back to this slide and remind yourself where that is and how to get the discount, or reach out to us and I'd be happy to talk with you. So the tumor microenvironment is this signaling environment that is either sending growth signals or stop signals to cancer physiology and cancer cells, affects whether or not we have tumorigenesis and proliferation and metastasis or not. So we want to be able to monitor that, and then we want to be able to influence that. And so that really comprises the environment around tumor cells. So that might be the lymph, the blood vessels, immune cells, fibroblasts, inflammatory cells, cytokines, etc. It also considers the extracellular matrix into which the tumor cells can invade. And so we want to have some sense what's going on. So that's the point of this lecture. And a wonderful, now retired integrative oncologist, Don Abrams, he has this lovely way of saying that I tell my patients I think of cancer as a weed. Modern oncology is focused on destroying the weed, while integrative oncology concentrates on the soil the weed grows in, and on making the soil as inhospitable as possible to the growth and spread of the weed. And that's what we're talking about here today. So what we want to do is create an environment that's inhospitable, not permissive to the development of growth and metastasis of tumor cells. Pardon me. And why this is important is right now in the United States, 1 in 2 men and 1 in 3 women will be diagnosed with cancer sometime in their lifetime. Now, think of sitting at a dinner table with 6 people, and 2 of the men and 3 of the women might already have had cancer or will have cancer. It's pretty daunting. And so the good news is a lot more people are surviving cancer. And so we're going to have many more cancer survivors, especially baby boomers, my generation, are now in the high-risk demographic for getting a cancer diagnosis. So you can see the number of cancer patients and survivors is going up over time. So this is the target patients that really aren't being served by oncologists, people can live with cancer as a chronic illness for a long period of time, and they are looking for guidance with diet and what herbs and supplements they can take and how to not have a recurrence. So this is where we come in a functional medicine, naturopathic medicine model. And so a lot of patients come to us or are looking for us after they've been through cancer so that they can restore their health and not have a recurrence. So the need is just huge. I was just telling my host here that I have a 4-month waiting list, and this is my motivation for training you. So what we know is that primary care providers really don't have any training in how to meet the needs of these patients. And so my mission is to help you understand how to recognize and manage the cancer terrain and reduce risk and reduce progression and help people have better outcomes. So this is how I think of the cancer journey. So people will come in when they've just been diagnosed. They might come in when they are undergoing treatment and need side effects management. They may come in after treatment, want help with recovering. And then there are patients who are in remission and want to stay in remission and their life is beyond cancer, want to keep them there. But we want to be able to monitor them for little microscopic signs of recurrence, because the oncologist is just looking for macroscopic signs of recurrence. And then there's this large population of patients living with cancer as a chronic illness who really need our support long term. So think about breast cancer patients who are on long-term hormone therapy, prostate cancer patients on long-term hormone therapy, lung cancer patients on long-term immunotherapy. They're all dealing with side effects and some compromise to their health. So they need a health plan, not just a disease plan. And that's where we come in. So we have the opportunity to transform their outcomes and their prognosis and their risk profile. We have the opportunity to enhance their treatments, help them manage their short-term and long-term side effects. But bottom line, we're coming in as the health expert on the team. And I always tell patients, you need a team. You need the disease experts, that's your oncology team, and you need health experts to make sure you have a plan for your health and that your outcome is health long-term. And oncologists aren't interested in health at all. Now, when you start to study cancer, think about cancer. There's a beautiful model that's called the Hallmarks of Cancer. And this was developed in the year 2000 by Weinberg and Hanahan. And they identified characteristics of tumor cells that help tumor cells to survive and to co-opt our normal physiology for their own gains. So you want to understand these characteristics of tumor cells, because this is where you have leverage. This is how you can disable the tumor cells, because they're using our physiology to survive. And so we'll look at some specific things, and you'll have some concrete examples. So we're going to look at selected biomarkers in this terrain, and we're going to think about how we can influence the terrain. So in this lecture, we're going to focus on some of the factors. And as you learn my Outsmart Cancer system, you will learn about all of the hallmarks of cancer, and then where is the leverage in diet, lifestyle, nutraceuticals, botanicals, IV therapies, acupuncture, Chinese herbs, naturopathic, Western herbs. Where is the leverage to alter this environment? So first we have to be able to monitor that environment and understand how to measure biomarkers so that we can also measure if we've changed it in a positive direction. So one of the facts of tumor biology is hypercoagulation. And hypercoagulation is a fact of cancer physiology, and it is correlated with the stage of the disease and the aggressiveness of the disease and the prognosis. This is what it looks like when there's a web of fibrin and platelets, and this makes a little raincoat over the tumor cell, and the tumor cell can hide from the immune system, and it can also hide from drug treatments and our herbal treatments. And so we want to reduce coagulation, not only so the patient doesn't have a risk of stroke or a heart attack or a thrombus, a pulmonary embolism, so that we reduce that risk, but also we reduce this risk of the tumor being able to hide from the immune system and from a therapeutic plan. So in the primary care setting, if you see early signs of coagulation, think that it's possible that it's not just a cardiovascular risk factor, but one of the earliest signs of cancer development is an elevation of clotting factors. And I'm going to show you what to measure. And so you want to start thinking, maybe I'm looking at early cancer physiology, because you are maybe the person who's going to see that first. And that's why this is so important. So this also helps us understand the aggressiveness of the disease, progression, and helps us keep patients more safe when they have surgeries, etc. So let's look at what it means when we have activated coagulation in the tumor microenvironment. We will see concurrently that the tumor markers are higher. There's more tumor mass. There's more tumor burden. It's in a more advanced disease, the more coagulation you have. You will have invasion into the blood vessels and into the stroma and the extracellular matrix. This is an invasive physiology. You'll see more lymph node metastasis, more advanced disease, more aggressive disease. You'll see whole body inflammation ramped up. And this is a person who has more disease, the more inflammation you see. So that's the big idea. We'll also see increased inflammation and coagulation during certain therapies that are pro-inflammatory, like chemo and some of the newer immunotherapies. So our goal is to identify these early signs and to realize a clot is being formed, and to also realize that cancer patients overall have a higher risk of a thrombus, and that patients with hematologic, meaning non-solid tumor malignancies like the leukemias and the myelomas and the lymphomas, have a 28-fold higher risk of developing a thrombus. And so I monitor them, and sometimes oncologists monitor coagulation and sometimes they don't, because they don't treat it, because their drugs are too strong, they're true anticoagulant. But we have things in our toolbox can take patients away from this thrombus risk. That's what I want you to learn, is how to identify it, what you can do safely while a patient's even undergoing treatment. And so overall, patients with metastatic disease could have a 20-fold higher risk of a thrombus. So it's really important. And also, it's one of the reasons cancer patients die. They don't die of their cancer always. They could die of a thrombotic event like a pulmonary embolism or a stroke or a brain bleed. And so what's really important to monitor this and manage this. So here's an infographic that shows you the tumor will throw off these microparticles called tissue factors. And these trigger a response of the thrombin and fibrin cascade. And so you'll end up with fibrin fibers, these sticky proteins, and then they form that mass that I showed you at the beginning. So platelets are in the middle, and then this sticky protein fibrin is holding this all together, and that's what a clot is. And so I'm going to show you what that looks like. And so this is what it looks like when your blood is too sticky and when you have a pulmonary embolism. And so you can see how that would obstruct normal circulation and cause a stroke or a heart attack, cut off blood supply. That's why it's so important. So we can really impact survival and morbidity and mortality. We can individualize care, and we can really improve prognosis and quality of life. So here's what you want to look for. You want to look at the leukocytes. If you start seeing leukocytes going up, then there's a lot of inflammation, and that's going to drive thrombin generation and platelet adhesion and thrombus formation. Of course, you want to watch platelets. If they start climbing over 350, then you have sticky blood, and the inflammatory cytokines are going up at the same time that's happening. So you should just know that. Interestingly, hemoglobin can go down when there's more clotting, and fibrinogen activity will go up, D-dimer will go up. So I commonly am looking at a CBC, and I'm commonly looking at fibrinogen activity and D-dimer. So, as patients get over 50, you want to monitor cardiovascular risk anyway. These are good things to monitor, but keep in mind, it could signify cancer risk as well. Patients with a high BMI, obese patients, have more inflammation and more risk of thrombus as well. Obesity, high body fat is also a risk factor for cancer and cancer recurrence. if you have elevated body fat, a high BMI, and if you also have insulin resistance and hyperinsulinemia, you have a 40% higher risk of developing cancer and of having a recurrence. So there are many things we do for patients to help them lower their recurrence. So C-reactive protein also will be elevated in many cancer patients. Sometimes you'll see that. You'll see a really high CRP, like maybe a 15 or a 20, and that's either an infection or that's cancer, typically. And so you want to understand what it looks like, what the profile looks like. So these are commonly lab tests that you're ordering and looking at. There are some great papers. So I have a lot of references in here that I'm just going to fly by so I can get through the lecture, because I want to get to all the big ideas here. But here's the first thing you do. You order a CBC with differential, and you order a fibrinogen D-dimer, and you order a C-reactive protein on all your patients, and watch that. And if you have a patient for a long time, you'll see trend, and then you'll understand when something's changing. And a lot of references in here for you about this. Also, of course, if somebody has thrombus risk, they're going to have more risk of a clot during a surgery. So you want to inform the surgeon that your patient is hypercoagulated so that they're safer in their surgery and their care is safer. So what can we do? What are the interventions? Curcumin is something we talk about in every cancer lecture because of its impact on cancer physiology, but it also has antiplatelet, anticoagulant, anti-inflammatory activity. So I would say if you're new to using nutraceuticals and phytochemicals in pharmacologic doses, start on the low end, start safe, around 2 grams a day. And then as you understand how it influences patients and you're monitoring their blood, you can go up higher. I will often give 4 grams a day to control tumor biology and to reduce thrombus risk. That's kind of my typical dose for most patients. A lot of people don't realize that resveratrol has anticoagulant, antiplatelet activity. And so we use this in cardiovascular disease and cancer care also, but remember now that it also has antiplatelet, anti-aggregation activity. And so also that same dose range, I usually give 2 to 4 grams a day. Now, omega-3 fatty acids, most people are aware of their ability to reduce thrombus risk, but they also, of course, are super anti-inflammatory and also inhibit angiogenesis and VEGF, which I'm going to talk about momentarily. So angiogenesis is the characteristic of tumor cells to make their own blood supply, and VEGF, vascular endothelial growth factor, is the signal that initiates angiogenesis. I'm going to show you an infographic about that. And then remember that the omega-3s also reduce cell adhesion and stickiness. And so if a tumor can't hold itself together, it requires stickiness to hold itself together. If we inhibit that, then a big mass can't form as easily, and it's also more difficult for the tumor to invade into other tissue. So we have curcumin, we have resveratrol, we have omega-3 fatty acids. Here are your references. A lot of people don't realize that ginseng also is anti-thrombus, anti-angiogenesis, and also influences tumor biology. It also influences the patient's experience of fatigue, helps with stress adaptation and resilience. And so I'll use about 3 grams a day. You have to really think about that these patients, if you have an active cancer patient that you're supporting their health, they need pharmacologic doses of botanicals and nutraceuticals because we're not just trying to produce health, we're trying to actually change their biology in a significant way, in a therapeutic way. Now, this is one of my most favorite herbs. It's available in freeze-dried granules and also liquid extract. And it is either listed as Salvia milturiza or Danshan, or sometimes you'll see it as red sage root. It's one of my favorite herbs. It has a multiplicity of actions in the tumor biology, but one of its real gifts is that it's an anticoagulant. And so it's really one of my go-to. It also inhibits fibrosis, which happens, like, for example, in patients who've had digestive system cancers, colorectal cancers, and ovarian and gynecologic cancers, so all kinds of fibrotic adhesions in their pelvis and abdomen. And Danshen is really great for inhibiting fibrotic formation and also reducing it once it's formed. So it's all about stickiness and inflammation and thrombus formation. One of my absolutely favorite herbs. And on this slide, you'll see it inhibits PI3K kinase. This is one of the drivers in most tumors. And so there are drugs developed to inhibit PI3K kinase, but we can do that with herbs. So Danshen does that, and also hinokiol is a phytochemical from magnolia bark, does that as well. So a number of references for you here. Now, it's also important to understand copper physiology in cancer. Copper drives angiogenesis, and angiogenesis, this blood supply being brought to the tumor, drives the exponential growth of tumors and their spread via metastasis. So I'm going to show you how that happens. So it's angiogenesis, of course, the ability to make new capillaries is part of how we heal wounds and incisions. So it's a normal part of physiology that is co-opted by the cancer cell for its own growth and travel. So this little blue ball is a mass of a few tumor cells. And so as a mass of tumor cells grows, the middle of it becomes hypoxic and can't get any nutrients. And this causes stress in the tumor cluster. And this initiates the secretion of vascular endothelial growth factor and another signaling molecule called Hi1Fa, hypoxic endothelial factor. And so these are signals that cause the capillary to bud out towards the tumor mass and actually give it a blood supply. Once that blood supply is there, then all the nutrients that come through the blood are there for those tumor cells, and they can grow exponentially. They can also then enter the lymphatic and circulatory system and travel and to other sites of the body, and that's what metastasis is. You'll have a primary tumor, and you'll have secondary and tertiary tumors in other sites like lymph nodes, and also in the brain, the lungs, the liver, and the bone marrow, and the bones themselves. And this, you'll see that where you get metastatic lesions is where there's more blood supply, because that's how these cells are traveling around. And so this is where we see metastasis. So what we want to do is try and inhibit this process of metastasis. So you can, if you have a patient with a cancer history, let's say somebody comes to you, you take their history, and they are a breast cancer survivor, or a lung cancer survivor, or a colorectal cancer survivor, or a gastric cancer survivor. As a matter of following them long term, order serum copper, serum zinc, and ceruloplasmin, the copper storage molecule, because you want to track them over time. And if you see a rise in copper and ceruloplasmin, you will suspect that maybe they're having a recurrence, so that the signaling has started. And so there's some really interesting data on the efficacy of lowering copper in patients who have tumors and tumor formation, and in patients who are in remission in preventing a recurrence. And so if you monitor copper in your patient, then you see it spike. That's a sign that there may be microscopic cancer activity. And so there's really great studies. I've listed a lot of them. And there's a Dr. Vadat who is still doing active studies on copper and copper lowering. So one of our interventions is tetrathiomolybdate, which is a compounded drug of molybdenum and sulfur, which actually chelates copper out of the body. So if you deplete copper levels, then cancer growth is inhibited. So it's a way to put the brakes on cancer. And so you monitor copper and ceruloplasmin. If you see it rising, you suspect that there's cancer activity, and you can, or say somebody comes into your practice who's a cancer survivor and they want to know how to prevent a recurrence, controlling copper physiology is part of that plan. And so there's some of Dr. Vadat's studies are here if you want to read about this. So what do we do? So oral copper depletion, or and also inhibiting the amount of copper exposure that a patient has. So you want to tell patients don't cook with copper cookware. You want to have them filter their water. So if they have copper pipes, the copper is pulled out of their drinking water. You want them to use a shower filter. And then we want to give them supplements that don't have added copper. So anybody who's a cancer survivor or undergoing cancer treatment, living with cancer as a chronic illness, you want to not use supplements with copper in them. So copper-free multis, copper-free bone formulas, copper-free musculoskeletal formulas. You want to be mindful of not adding copper to this patient population supplements, because the cancer cell is using copper to grow and progress and metastasize. So these are our goals for serum copper, ceruloplasmin, and zinc. And we like to see zinc and copper in kind of a 1-to-1 ratio. And if we even want to do better, we want to have zinc be higher than copper. And so if you monitor this, you can take control of the cancer terrain, influence the tumor microenvironment, and create a body that is more inhibitory rather more pro-growth for cancer. So that's the goal, is to create a physiology that doesn't provide cancer cells with what they need. And so by lowering copper and increasing zinc, you can do that. So if a patient has very high copper, we do oral chelation with tetrathiomolybdate. That's a prescription item. It's made by compounding pharmacies. But we can also mildly deplete copper with supplements that have sulfhydryl groups on them. And so N-acetylcysteine, which is now being regulated by the FDA and may not be available to us, but it probably will be available by prescription. Alpha-lipoic acid is a mild copper chelator. And then you elevate zinc, because copper and zinc compete for binding sites, and then avoid copper intake by really taking out the super high copper foods like organ meats and liver, and some of the shellfish like oysters. And then we mentioned copper cookware and copper containing supplements. You can't give anyone a copper-free diet because all food has copper in it, but we don't add copper. We're going to take control of it. Okay? So we talked about coagulation so far, monitoring it, managing it, keeping people safe from a thrombus. We talked about monitoring copper and ceruloplasmin. Both of these, hypercoagulation and copper, could be early signs of a cancer occurrence or a cancer recurrence. And by optimizing those, you keep people safe and you keep their body less hospitable to cancer. Vitamin D falls into this category as well. So how does vitamin D influence cancer? In a multiplicity of ways. So if we optimize vitamin D, then we get the protective effects of vitamin D for cancer. And so this influences gene transcription, growth signaling, apoptosis, which is the normal cell death mechanism to get rid of aberrant cells. Cancer cells lose this signaling property. And so there you have an aberrant cell, a cancer cell, and it doesn't self-destruct. It doesn't go through apoptosis. And so turning apoptosis back on is a way to get rid of cancer cells. We also get enhanced DNA repair. Remember, there's nuclear receptors for vitamin D. It enhances antioxidant protection, immune modulation, super important for robust immunity and normal immunity. It enhances the differentiation of tumor cells. A more complex, more differentiated, less primitive cell is easier to treat, easier to target. If cells become dedifferentiated, cancer is very, very hard to control. So we want to promote differentiation. So that's one function of vitamin D in the cancer setting. Vitamin A also does that. Of course, vitamin D does decrease pro-inflammatory cytokines. That's also why we use it in autoimmune diseases. It does decrease invasion into the extracellular matrix because it influences the adhesion stickiness of the cancer cells. And it also decreases angiogenesis and metastasis and inhibits this capillary supply to the tumor cells. Super important. So if there was a drug like that, it'd be a blockbuster drug. So there's a ton of research on vitamin D status and cancer progression, cancer occurrence, cancer risk, cancer mortality, affects all of those things. Tons and tons of studies. So let me show you how to measure it and how to use it. So in the cancer setting, I shoot for a blood level of around 70 to 80. This is also very protective of cardiovascular disease. And that level really cannot be achieved by diet or being out in the sunshine. People often ask, well, what about vitamin D and exposing your skin to the sun? In modern life, we really don't expose much of our body to the sun. And I always say you'd have to run around on the equator naked all day long to make enough vitamin D to achieve a therapeutic level. So it's not practical. So we give vitamin D, we always give it with vitamin K because vitamin K shuttles the calcium into the bone. And so, of course, one of vitamin D's other effects is healthy bone metabolism, mineral metabolism. And so we want to make sure that the calcium goes to the bone, and vitamin K is important in that. But vitamin K has some anti-cancer activity. So I use vitamin D3 plus K combination supplements typically, and I'm measuring the blood to see where 25-OH vitamin D is on all my patients, okay? So the research shows between 55 and 80 is where you get these effects, these immune and protective effects, but I usually shoot for between 70 and 80 for my patients. And so you just monitor vitamin D in all your patients, and you'll see that cancer patients utilize vitamin D at a much higher rate, and you have to therefore modulate their oral dose to keep their blood level at those higher levels, which offer them protection. Now, inflammation is so much of a factor in many, many diseases, but cancer itself is an inflammatory disease, and the presence of inflammation in tissue leads to more oxidative stress, more DNA damage, more aberrant cells, damaged mitochondria. So having chronic inflammation is cancer risk, but that cancer itself drives more inflammation, and that level of inflammation is correlated with survival. The more inflamed a cancer patient is, the poorer their prognosis is. And you will see, if you start monitoring patients who are going through cancer treatment, or you are seeing them and you notice a really high CRP and their vitamin D is low and their inflammatory markers are high and their white blood cells are high and their hemoglobin is low and their D-dimer and fibrinogen are high, that's a picture of someone with a tumor. And so you'll start to recognize it if you order these things and follow patients over time. And if you're supporting patients through their treatment, you'll see as their tumor burden goes down, all those things go down too. And so these are readily available blood tests. And so just to understand these relationships so that you, because of the prevalence of cancer, these patients are in your practice. So you want to be able to monitor patients long-term and recognize early signs of occurrence or recurrence. And you also want to help people stay out of a physiology that is pro-carcinogenic. And so that's what we're looking for. And so I just said cancer cells themselves produce inflammation. They secrete chemokines and cytokines, and then immune cells also secrete these. And so you can be in a soup of a lot of triggers of inflammation in cancer physiology. So we really, really want to reduce inflammation, take good control of it. My goal is to have a CRP under 1.0. So this is how inflammation affects tumor biology. You will see that as a normal cell turns into a cancer cell, you have many, many more signaling molecules that are part of the cancer biology and the cancer terrain. So you'll have a cell that becomes damaged, and then that gives the potential to become a cancer cell. And so some of those damaged cells will self-destruct, go through apoptosis or autophagy and be recycled. But the cells that survive may become a cancer cell, and then they develop survival mechanisms, and there might be a coat of fibrin around them so they can hide from the immune system, and all these growth factors ensue. Then they learn how to replicate. Then angiogenesis happens, and then they have this wonderful blood supply, and then metastasis can happen. And so this can be initiated. Every step of this cancer journey, this cancer biology can be initiated by an inflammatory signal. And of course, the upstream source is NF-kappa B, which then from that flows many of the inflammatory cytokines, things you're familiar with like TNF-alpha and interleukins and COX and matrix metalloproteinases. These are all your inflammatory cytokines that are downstream from NF-kappa B. Any place there's inflammation, inflammatory cytokines and triggers, this whole process is supported. And that's why managing inflammation is so important. Let me say that once a mass is found, it is likely that that process has been going on for 10 or 20 years. So we may never know the initiating factor. There may be damaged cells that the immune system controls over time. And then as a person ages and their immunity is less robust, that control is less. And that's why we see more cancer as people age. People are more inflamed as they age. And so by the time you find a mass, the initiating process has been there for some time. So oncologists make patients feel very urgent and like you have to start your treatment next week. We'll start chemo, then we'll do surgery, then we'll do hormonal therapy, then we'll have radiation. And patients aren't ready for that psychologically a week after diagnosis. So I always say to patients who I get to talk to them at their stage of their practice, their journey, I just say, look, this has been brewing in your body for 10 or 20 years, and you can take the time to adjust psychologically to what's happening to you. You can take the time to get second and third opinions and find the doctor you want to be treated by and put your team together and organize your personal life and organize for your kids and organize for your business so that when you go into treatment, you will have you'll be able to thrive and get a good outcome and suffer less. And so one of the things we can do is help reduce anxiety and the sense of emergency and urgency. Cancer is not an urgent cure diagnosis unless they're hemorrhaging and unless there's pressure on a nerve that is impeding function. But otherwise, it's not an urgent care diagnosis. It's a serious diagnosis. It needs our attention, but the patient has some time to organize their psyche, their emotions, and their life, and to pick their team and get more opinions. They have time to do that. So we're sometimes the person that says that to them. So inflammation is driving growth, proliferation, angiogenesis, metastasis. Inflammation is suppressing immunity. It is the main cause of cancer-related fatigue, and it is a contributor to cancer-related depression, and of course, it's involved in pain. So cancer patients need inflammation control all the time, and so my target is below 1.0. The studies give this target range of 1.0 to 3.0, but my goal for my patients is much better inflammation control than that. Lots of studies showing the relationship between inflammatory markers and cancer risk and progression and surgical outcomes. So lots of references for you. Now, another thing that you can look at inside the inflammation milieu is this ratio between neutrophils and lymphocytes. This is very important. If you have a CBC with a differential in front of you, which you will most of the time, if you order CBC, order it with a differential so you can see this. And if you're looking at somebody else's medical records or looking in patient portal at medical records, you will be able to calculate this ratio. So it's very, very prognostic. So I track it in all my patients, and I keep a spreadsheet of trend of all my patients of their neutrophil to lymphocyte ratio, because it tells you about the robustness of the immune response, and it tells you about the aggressiveness of the disease, and it tells you whether or not a patient is progressing or not, or has risk of progression. So a neutrophil to lymphocyte ratio of 4 or below is a positive prognosis of low risk of progression, low risk of recurrence. Neutrophil to lymphocyte ratio below 2 is super low risk. So you want to watch this, and you'll see it change as patients' tumor burden goes down, as their immunity is more robust, they will have this ratio go down. If they are having progression and their immune system's not responding, this ratio goes up. So you look at the CBC, find the neutrophils, you find the lymphocytes, you calculate the ratio. That's it. That's how you find it. And you will see that this correlates with other risk factors that promote cancer that are secreted by the tumor, other growth factors, other inflammatory cytokines will be a part of this profile of a poor prognosis, of a pro-growth prognosis, of an immune system not taking control of the cancer. So it's a great marker that you can always see, and there's a ton of studies on it. So inflammation control, we're pretty well trained in that. So I'll just review kind of how I think about it in the cancer setting, because by decreasing upstream as far as you can, NF-kappa B, of course, you're going to influence everything downstream. That's an inflammatory driver. But we'll be able to inhibit apoptosis. We'll be able to enhance cell cycle progression. We'll be able to control angiogenesis and metastasis. And we'll be able to control the secretion of cytokines and chemokines and proteases by the immune system and by the tumor. And so this creates an environment which is less aggressive growth can occur. So we've learned about NF-kappa B and inflammation in our training, but I just want to show you that a lot of the things that lower NF-kappa B also take control of cancer biology. And so think about the things you already know about that are anti-inflammatory in our Materia Medica. So a lot of those are phytochemicals. Well, of course, the omega-3s, but indole-3-carbinol, the sulforaphanes, a lot of the pigmented phytochemicals, also things like alkaloids like berberine, things like allicin from garlic, the tocotrienols inhibit proliferation in NF-kappa B, geraniol, zerumbone, which is from ginger, silymarin, which is from milk thistle. So you can take a look at this slide, but there's things that we already use in the setting of inflammation that apply to cancer inflammation also. And then the triggers of inflammation are also triggers of cancer. And then some of those are frank carcinogens like tobacco, like sun exposure, like endotoxins, like mycotoxins, like radiation exposure, like environmental toxins, like heavy metals, things that really disrupt the physiology of a cell can turn it into a cancer cell, and then can also be triggers of inflammation. So this is something we are well schooled in our training. So I want to introduce you to a few things you're familiar with and a few things used in cancer specifically. So curcuminoids from curcumin are fantastic at lowering COX-2, NF-kappa B, TNF-alpha, inflammatory cytokines, IL-6 and IL-1, which are very common in cancer. You see elevations of these in cancer, usually 2 to 4 grams a day. Omega-3 fatty acids we spoke about already in terms of coagulation. And again, I dose these usually 2 to 4 grams a day in my patients. The omega-3s also decrease the lipooxygenases, and that is generated a lot by the lung tissue. So COVID patients, as well as lung cancer patients or patients with lung metastases, often have elevated lipoxygenase, and that also is well managed by boswellia. So often put that in. If that's a factor, boswellia also decreases inflammation in the large intestine very effectively. And so if colorectal cancer patient or a patient who's having a inflammatory colitis as a reaction to an immunotherapy drug, for example, when we think about inflammation management in that setting. Probiotics, of course, having a healthy microbiome is a key to inflammation management, both locally and systemically. We all know that. But there are some phytochemicals that are particular to the cancer physiology that I use quite a lot. So bicalene is a polyphenol that is found in Scutellaria bicalensis, Huang Qin. And this is one of the most widely used anti-tumor herbs in the Chinese Materia Medica. And you will see in formulas of Chinese herbalists treating cancer patients, you will always see Scutellaria bicalensis. It has a number of phytochemicals, bicalene, bicalin, wagonin, and berberine are all phytochemicals that are active in the cancer physiology and in inflammation management as well. Berberine is contained in Scutellaria bicalensis, but we can use berberine by itself. We often use it, of course, in glycemic control. It also has some anti-inflammatory and antimicrobial properties. So it helps to regulate the microbiome. And it's one of the best ways to, if you're trying to normalize the microbiome, I always include berberine because it helps the flourishing of the healthy bacteria. And it helps us to utilize some of the phytochemicals. It creates an environment that makes the phytochemicals more absorbable, more utilizable. So I often use it for a variety of reasons. One of my favorite phytochemicals. And then resveratrol, not only is it anticoagulant, we talked about it earlier, but it also is anti-inflammatory. And so, as we know, we mostly studied resveratrol also protects telomeres, so it's really protecting the DNA as well. So you can see its application in the cancer physiology. And you see that phytochemicals and molecules from nature are always pleomorphic. They're always multitaskers. And so we can learn a handful of big levers and strong interventions that hit many, many points in our cancer terrain, our tumor microenvironment. And so that's how you want to think about it. This is a nice infographic showing all the activities of curcumin in inflammatory pathways. And there's a lot of studies on all of these phytochemicals and inflammation control. And also we get some what we call chemosensitization by normalizing the tumor microenvironment. You can see resveratrol can suppress tumor growth signaling and increase tumor control signaling. And so this is the beauty of molecules from nature, is we get these effects that are like a symphony. And so it's a very powerful thing to do, to be able to hit all these pathways. There's another infographic I often put in my slides. I don't think it's in this lecture, which shows that curcumin interacts with over 100 signaling molecules, receptors, or genes that influence cancer biology. Resveratrol interacts with over 50. So these are powerful, big levers. They should be in our protocols. Omega-3 fatty acids, of course, there's a lot of research on that and inflammation. Probiotics we talked about, controlling inflammation. What's interesting about that is they'll downregulate pro-inflammatory cytokines, but you get an upregulation of IL-10, which is anti-inflammatory as well. So it's really great for the immune activated colitis that comes with the immunotherapy drugs, the PD-L1 inhibitors. This is a slide on bicalene, the scutellary biocolensis that I just mentioned, and showing you the pathways, and wonderful reference for this. I use this herb a lot in my formulas. Berberine, here's some references for that. Berberine is actually found in a lot of our botanical Materia Medica, and both the Chinese and the North American and European Materia Medicas, you'll find berberine in a lot of plants. And it's a bright yellow alkaloid that's super bitter. It's what makes golden cell bright yellow. With some references for that. Ginger is also one of our great anti-inflammatories, and of course it's a wonderful digestive, and it's a wonderful expectorant. And so we again get a multitasker. A lot of cancer patients' digestive fire is damaged by chemotherapy treatments. We always want to be supporting good digestion for them. So not only can we control inflammation, but we can also use it for inflammation. And ginger actually is one of the best anti-nausea drugs. So we can use it in place of some of the pharmaceutical anti-nausea medications, which really constipate patients. So you have to just give it in higher doses, and every 2 to 4 hours, because it has short duration of action, unlike drugs. But patients can control their nausea with this as well. So lots of references. I just want to mention also that you should be tracking ferritin in your patients. We think of ferritin as an iron storage molecule, but in fact, it is also elevated in the cancer biology. It's an inflammatory marker in the cancer setting, and so is ceruloplasmin. So if you see these up and then this other ecology developing, then you think maybe we have cancer going on here. So it's a prognostic biomarker in the cancer setting. So here's a couple of things we talked about and a few we didn't. On the bottom left, we see albumin. If albumin is falling and is low, that's a sign of disease progression and increased risk of mortality as well. So we do look at the albumin globulin ratio as well. So you'll have that if you have a metabolic panel, just a routine metabolic panel in front of you. You will also have an albumin globulin ratio there. And so as albumin goes down, survival goes down as well. So you can be tracking that. Gives you a sense of the direction the patient is going in and where their risk is. Or if you see that, you see that, then maybe they have a cancer biology that nobody else has identified yet. That's why I teach this, really. I want you to be the early diagnosis person, because you are schooled in this physiology and you're looking for these red flags. Okay, so low serum albumin associated with increased mortality, basically. Okay, so LDH, lactic acid dehydrogenase, is also something I recommend that you order in your patients over 50, because it is a red flag. As it goes up, it's a red flag for cancer cell biology. It is a tumor marker in essence, and it will be elevated in patients with active cancer typically. And you can also order the LDH isotypes, and they'll tell you what tissue it's coming from. Pardon me. So I look at that. Why does it go up? Lactic acid goes up when there's more tumor cell activity, because tumor cells have a different biology than healthy cells. They are dependent on glycolysis, and the byproduct of glycolysis is lactic acid. So you'll see lactic acid dehydrogenase go up when you have more glycolysis, more glycolytic cells, and that's typically a cancer profile. So you can watch that. Lots of data and studies on that. So you can think of that as well. So I'm gonna go through a summary here. I know that was kind of quick, but I want to leave time for questions. And so we'll have about 20 minutes for Q&A. And so let's just summarize these things that we went through today. So we said, okay, if you have a CBC with a differential and platelets in front of you, then you're going to be able to see coagulation and inflammation, and you're going to be able to also see if the bone marrow is in trouble. You're going to be able to see that lymphocyte to neutrophil ratio. So you're going to be able to get a sense of the patient's vulnerability, their disease burden, and the direction things are going in if you're tracking them. And so, more data points, you get more insight. One set of data is not useful by itself and has to be taken in context. In your comprehensive metabolic panel, you can watch the albumin globulin ratio. As that goes down, the patient is becoming more weak and less able to be resilient. We mentioned looking at fibrinogen and D-dimer activity in the context of thrombus risk and hypercoagulation. We mentioned CRP, of course, in the setting of inflammation, but that also goes up when you have hypercoagulation, goes up when you have more tumor burden. We talked about all the functions of vitamin D in the cancer biology. We noted that ferritin and ceruloplasmin are acute inflammation markers in the cancer biology. We noted that elevated copper and ceruloplasmin are signs of angiogenesis and metastasis, and that looking at the ratio between copper and zinc is useful so that you can optimize that to make copper less available to the cells and therefore inhibit angiogenesis and metastasis. And then we spoke about lactic acid dehydrogenase being actually a marker of tumor biology, then tumor activity, due to the dependence of glycolysis for tumor cells that cannot use the electron transport change efficiently to make ATP. They depend on glycolysis to make ATP. So that's what we talked about today. Okay, and then our Materia Medica, we talked about things that you're familiar with. I didn't mention EC/GC, but it interacts with inflammation and coagulation as well. We talked about a number of botanicals and nutraceuticals. I didn't mention Ganoderma in this lecture, but it is an anti-inflammatory as well as an immune stimulant. That's reishi mushroom. Give that about 3 grams a day. And all the B vitamins are involved in the metabolism of drugs and detoxification. The tetrathione is the TM that we talked about as a compounded prescription oral copper chelating agent. I use that quite widely in patients who are in remission to reduce recurrence. And so this is a Materia Medica, which you should be able to have access to and understands relation to your labs. So look at the labs, you see the abnormals, you put a treatment plan together, and then you measure again and see if your dosing and your choice of interventions is actually moving the physiology towards cancer resistance and health. Okay, and that's how we use this. Just to remind you, if you're interested in studying with me, I'm desperate to train more people to do this, and you can have a 10% discount for a limited amount of time, and that includes a discount on the live mentoring, monthly mentoring with me, if you'd like that. And then just to remind you, you have this free bonus of an article I wrote on this topic. So now we can take Q&A for about 20 minutes.
All right, thank you so much, Dr. Chilkov. The first question I've got for you here is, what is the name of the red sage root and what is its dosage?
The red sage root is on the slide that is titled Salvia miltiorhiza, and usually is used 2 to 4 grams a day. Salvia, as in sage, S-A-L-V-I-A, miltiorhiza. So that was the slide with a picture of a red root on it. And so there's a number of references in this lecture. You have access to these slides. So you can go back to that slide to see that.
All right, our next question here is, what about individuals with Lynch syndrome? How can we keep an eye on them and try to prevent or postpone metastasis?
Okay, so for people who don't know what Lynch syndrome is, it's a genetically transmitted disease which causes the extremely high risk of multiple cancers in multiple tissues and organs. And it's very, very, very challenging disease. These patients often die and often have a very poor quality of life because they have tumors in multiple systems. So they might have lung tumors, colorectal tumors, liver tumors, etc. So these patients are followed very closely by their physicians because their risk of developing cancers is very high, tends to run in families. It is genetically transmitted. When a patient has certain types of cancer, like colorectal cancer diagnosis, usually they're also checked to see if they have Lynch syndrome or not. So, you want to get used to reading the medical records of patients like this so you can see how thorough their oncologist was. My experience, I have patients all over the world and all over this country, and my experience is that in New York and on the coast, the West Coast, oncologists do very, very thorough, detailed workups of tumor biology and genetics, and in the Midwest, they don't do much at all. And so if we want to also take a role of educating our patients, we can say, you need a more thorough workup to see what's really going on and to see how aggressive your disease is and if there are any other factors that need to be addressed. And so we often can play that role of educating the patient, empowering them as well. So Lynch syndrome, if I have a patient with Lynch syndrome, then I know they're seeing an oncologist on a regular basis. And so I will do my tumor microenvironment cancer terrain biomarker analysis, which is larger than the things we talked about today, just due to the constraints of time. But I'll do that, and the main ones we talked about today, and I'll track that in them about every 2 or 3 months, so I can see the direction that they're going in and see if I can exert some control on cutting down the growth signaling in a patient like this. This is a very challenging disease syndrome.
Okay, next question is, do you recommend testing serum copper and zinc levels over RBC copper and zinc levels? If so, why?
Usually the data is about the serum levels, but in our practice, we know that red blood cell levels are more accurate. So if you have a reliable lab and you can order red blood cell levels, then absolutely do Most of the research is using serum levels. If you read studies, you're going to be reading serum levels.
All right, next question is, what are your diagnostic thoughts and potential nutraceutical interventions for breast cancer survivors with persistent low WBCs and ferritin after active treatment?
So the reason that any cancer patient who has had chemotherapy has low white blood cells and potentially low red blood cells, low platelets, is because chemotherapy damages the bone marrow. There's what we call bone marrow ablation due to chemotherapy. And so the goal then, when we think about root cause in our model, the goal is to try and repair the bone marrow. And so white cells in particular, astragalus root, astragalus, has a lot of research on that. And there's also a formula that I use, and it is made by Health Concerns. It's a modern Chinese herbal formula, and it's called Marrow Plus. So I give about 3 to 6 grams a day of astragalus, and I give 3 tabs 3 times a day of the Marrow Plus if the levels are really, really, really low on either white or red blood cells. I'm just going to talk about bone marrow function more generally too. Platelets are supported by melatonin. So if you see low platelets, you can give 20 to 40 milligrams of melatonin on a daily basis. This also inhibits some cancer biology, can be given at bedtime to just match the cycle of melatonin. That's a therapeutic level of melatonin, of course. Ferritin, if ferritin is high, then, and let me just say, acupuncture is fantastic for helping to restore bone marrow function. So usually the point stomach 36 is the main point. You can do a needle or moxa on that point, heat therapy or needling on that point. Once or twice a week over a 3-month period, you can help repair the bone marrow and keep the cell counts up that way. Now, elevated ferritin, I think you said elevated ferritin. If ferritin is elevated, then you have an inflammatory situation you need to address. If ferritin is low, then you have low iron storage. But in cancer patients, we don't want to ramp up the iron stores too much because cancer cells not only use copper for their own growth, but they use iron for their own growth. So I'm happy if ferritin's in the, lowest quartile of normal, kind of at the top of that quartile. It doesn't have to be super high. We want patients to have ferritin stores, so if they have blood loss, they have some iron stores. But I don't like to see high ferritin. It can also be a signal of cancer activity, but by itself, it's not. By itself, it's an inflammatory marker. When you see this sort of gestalt of all these factors we talked about today moving together, that's what cancer biology looks like.
All right, our next question is, I'm curious about Dr. Chilkov, how Dr. Chilkov deals with mental, emotional, and spiritual aspects of cancer patients. It seems like the need would come up with cancer.
It's huge. It's huge. Of course, it's huge. And we want to always treat the whole patient. So you have to get to know your patient, to know how to connect with them and have them really trust you so that you can have an intimate, frank, honest conversation with them, because it's all on the table. But I've learned that I also need to take cues from the patient of when they're ready to talk about things. So I establish a relationship and a rapport where they know that I'm comfortable talking about any topic they want to talk about, whether that's how their sexuality's changed due to their cancer diagnosis, or they're facing death and they can't talk to their family about it, but they need to talk to someone about it, or just the anxiety that comes with cancer diagnosis and cancer treatments, and the disfigurement of the body, the pain, the sleep disruption. All of these things affect emotions and psyche and spiritual issues. So in my treatment plan, I have different sections. So I have a section on lifestyle, self-care, and resilience, where I give some tips about, and some resources. There's some books I like and some meditations online that I like, and tips for dealing with that. And then, I let them know that those conversations can happen with me. And I tend to have a lot of those conversations with patients, and I'm very comfortable talking about suffering and death. And so patients feel that, and but you have to let them give you the cue that they're ready to have certain conversations. The most important thing is to let them know at the first visit when you make their plan. It's important to address your emotions. It's important to manage your stress. It's important to uh, uh, use your own inner resources and the way you connect to the sacred and the spiritual. You name it to them, and make sure it's explicit that you think it's important and that you're happy to talk with them about all of that. And on the first visit, you have to choose what you're going to talk about. And for some patients, I just had a patient yesterday who's a new patient to me, and I learned that she grew up in Bosnia in war, and she had a lot of PTSD and early life trauma, and that her cancer was causing her to feel re-traumatized. So her stress was amplified because of that. And so I spent a large portion of the first visit talking about uh, just being compassionate to herself and understanding that that was happening to her. And then we talked about, what kind of care and support she can have to deal with that. Because cancer is very much like PTSD. It's one insult and one little trauma after another, the diagnosis, the biopsy, the surgery, the chemo, whatever it is. Every one of those things is a small trauma. And cancer patients often have the profile that fits a PTSD patient. So we have to be very sensitive to that. I always assume that the cancer diagnosis itself and what the patient is told about treatment produces anxiety in everyone. And so I speak to that on the first visit. And my goal on the first visit is that the patient feels less anxious at the end of the first visit than they felt at the beginning of the conversation. And that's a goal for my first visit. And that I hope that they feel a greater sense of agency, a greater sense of control, less urgency, emergency, and a sense that this is something that we can take control of. And so, you find your language, you find framework. In my course, it's very interesting. When I developed my own course, I had some colleagues beta test it, and everyone said to me, where's the module on how you talk to patients? Where's the module on how you talk to the oncologist? And so I added a module because I think language is powerful, and I have very particular ways of talking to patients and oncologists so that we can have open, trusting, respectful relationships and really work together. And so I have a whole module on all of that in my course because I feel it's so important. So that's a short answer to a big topic.
Okay, the next question we have here is, how do you modify testing and supplements for a patient with a long-term autoimmunity disease like Hashimoto, celiac, and new cancer diagnosis?
So all of our patients are going to be complex because of the age demographic of cancer patients. Most cancers occur over the age of 50. Patients are going to be comorbid. So they're complex patients. They're inherently complex patients. So you may have a cancer patient with mental illness or depression. You may have a cancer patient with autoimmune disease. You may have a cancer patient with diabetes. You may have a cancer patient who has atrial fibrillation, etc. Right? So these patients are going to be complex. I used to have a general functional medicine, Chinese medicine practice. I only do cancer counseling, advocacy, and support now. So while patients need to have their microbiome corrected, they need to have their autoimmune disease managed, they need to have their diabetes managed, etc. I am not their primary functional medicine doctor. And because I made that choice, I'm not up on the latest management of everything, although I used to do it. And I did it for 30 years. So you would monitor patients for whatever their, other health concerns are the same way that you do whether they have cancer or not. So how you are monitoring your Hashimoto's patients, you keep doing that. What you want to do is understand how the treatments they receive in cancer or how the disease cancer itself might make those syndromes worse. So cancer patients often receive steroids, so blood sugar goes up. Cancer patients who receive radiation to the head and neck and the throat, their thyroid will become inflamed. So you need to understand how to interpret the data that you are using to follow your patients in the context of their cancer disease or their cancer treatments. Certain autoimmune syndromes are ramped up when patients have immunotherapy, particularly the PD-L1 inhibitors and the checkpoint inhibitors. So you need to understand what the side effects of treatments look like and how they make other parts of the disease worse. So a patient on steroids is going to have hyperglycemia. They didn't just develop diabetes. That's a drug side effect. It's a drug side effect. A patient who starts on a PD-L1 inhibitor or a checkpoint inhibitor and develops thyroiditis, that's thyroiditis and ensuing hypothyroidism as a drug side effect. It's not autoimmune Hashimoto's from a life history of other triggers. So you have to understand how treatments also create pathology and how to manage those. But whatever your patient's history is, you're still going to monitor their same biomarkers, but you just need to understand it in context, and you need to understand whether you can manage it well while they're going through treatment or not.
All right, so we have time for one last question here.
Okay.
How can we know if some of the supplements interfere with Western medicines?
Well, that is a knowledge base that if you are going to work with cancer patients while they're undergoing any treatment, but that's to say generally, any patient of yours, welcome to America, is probably on a prescription drug of some kind, unless they've been committed to naturopathic medicine for a very long time. So most of our patients are taking prescription drugs. It is our responsibility to know drug-herb, drug-nutrient interactions, whatever patient we have. That is our responsibility as clinicians. And so that is a learning curve. And so I do teach about interactions with chemotherapy and immunotherapy and radiation and surgical risks as part of the management of cancer patients. But as a clinician practicing in America, most patients are on at least one, if not a handful, of prescription drugs. And so it is our responsibility to have that knowledge, education, and skill. And if you don't know, don't prescribe something to a patient who is on a prescription drug until you've done your homework and gotten the information. So you can sort of think through mechanism of action. So if you know that a certain drug is metabolized through the liver, which most drugs are, and then you're going to do a liver detox on a patient, you need to understand that that may change their drug interaction. You would be careful not to tell patients to drink grapefruit juice, but to, in fact, tell them to avoid it because it changes drug metabolism. It causes higher blood levels of drugs. If you are using things that I've mentioned that impact hypercoagulation, and a patient is already on a blood thinner, then you have to give very conservative doses or none at all until you are skillful and safe. So maybe you need a mentor to guide you if you don't have that in your training. And really, I think most of us didn't get great training in drug-nutrient, drug-herb interactions, and certainly as newer drugs come out. So there may not be research on natural therapies, but you can sort of reason it out if you know the mechanism of action of a drug and you know the mechanism of action of a botanical, nutraceutical, or phytochemical. You can figure out if they're going to interact. You can figure that out. We know some things like curcumin interacts with cyclophosphamide, for example, but in a negative way, but it enhances the action of radiotherapy, for example. So that's just a learning curve. It's a knowledge base you should have. And in the live mentoring, we can address that patient by patient. But it's knowledge we all need to have and continue to update for ourselves, because as physicians, we are responsible for what we prescribe and whether or not it creates a drug interaction. We are responsible for that. It's the wonderful question, and it's knowledge hard to obtain and hard to get mentoring by. I would say people like myself who've been in practice 30 plus years, we're your elders and we have a lot of experience with that, and we can teach you, happy to teach you.